Introduce our next topic presenter. Dr. Sullivan has presented, I think, at least 2 seminars or conventions now. And I am so happy that he agreed to present on this topic about Ozempic. And I see a lot of head shaking. So I will let Dr. Sullivan kind of talk about his background, and please help me in welcoming him.
Thanks, Judy. All right, thanks guys. Thanks for having me. Again, I'm Dr. James Sullivan. I'm a family medicine physician, work in primary care in a little city right outside Omaha in Fremont, Nebraska. I've been doing that for I've been practicing medicine over 20 years. So my topic today, first of all, if you come see me and you have a cough, you're not going to get any help. Sorry. Tylenol. That's all you're going to get from me. That was a great topic. But anyway, Ozempic. So Ozempic has been forefront in the media, I think, in the very near past. Celebrities are scrambling to get it for weight loss. You know, Housewives of Beverly Hills are trying to get it to lose weight. But so I wanted to bring this topic out. It's a new, Ozempic is part of a new class of medications that have come out to treat diabetes, and there's some other outstanding implications such as weight loss. So I wanted to give a topic kind of explaining that, not just on Ozempic, but mainly the whole class of drug. So is it a miracle drug? Well, I don't know if we can go that far, but I'd like to talk about it today and see if it comes close to that. So I'd like to list the benefits of this drug class, glucagon-like peptide 1 agonist drug class. It's a newer class of medications that have come out to treat for the treatment of diabetes. I'll speak briefly on what is meant by off-label use of prescription drugs. And then I'd like to demonstrate some of my anecdotal evidence of the use of these drugs, their efficacy and safety, just basically what my experience has been. So just in general, what is diabetes? Most people know probably what the disease of diabetes is. It's basically a disease that results in elevated glucose levels. So blood sugar, glucose, is a simple carbohydrate. Glucose is the main source of energy that the body uses to live. As a matter of fact, it's the only source that the brain uses. So I don't know if anyone's ever been on a protein diet, high protein diet like the Atkins diet. You tend to feel miserable because you're not getting a whole lot of glucose. You get headaches. That's why the brain's only source of energy is glucose. So we can't limit glucose completely. That's why when people get hypoglycemic or low blood sugar, it has a lot of neurologic side effects. So what is the problem with too much sugar or too much glucose? Well, high levels of glucose in the bloodstream are very toxic. So I tell patients, I like to describe it simply as, think of high levels of sugar as acid in the blood. So think about pouring battery acid down your kitchen sink. It's going to corrode the pipes. That's what high levels of glucose do in the bloodstream to arteries, veins, thereby over time corroding those pipes, and then organs start to fail. So that's what the problem is with high levels of glucose. Where does glucose come from? Obviously the food we eat, carbohydrates. So all carbohydrates that we ingest are usually broken down all the way to the simple form of glucose. In order for your body to use glucose for energy, to use glucose properly, you need a hormone called insulin. So insulin's a hormone produced by the pancreas. It is secreted in response to higher glucose levels, and it is required to process that glucose to make it into energy. Two main types of diabetes that we describe. Type 1, juvenile onset diabetes. This is where the pancreas no longer produces insulin at all. The beta cells in the pancreas, for whatever reason, stop making insulin, and so these folks are insulin deficient. We call it juvenile onset because usually these people are diagnosed early in age, childhood, adolescence, teen years. This process happens early in life, so we tend to call it juvenile onset diabetes, type 1. Type 2 diabetes, on the other hand, is much more prevalent. It's an epidemic, unfortunately, in our country. Type 2 diabetes is where the patient, you have plenty of insulin. The pancreas is still producing insulin. It's just that your body does not use that insulin properly to process glucose. So we commonly refer to type 2 diabetes as being you're insulin resistant. So you have enough insulin, your body's just resistant in using it properly to process glucose. The obvious end result of both of these conditions, it results in high glucose levels, and we gotta treat that as best we can. Because again, high glucose levels, toxicity in the bloodstream causes end organ damage. So among the many treatments for diabetes, the cornerstone of treatment for all diabetics, whether you're type 1 or type 2, is what you're ingesting. Diabetic diet. Everyone needs to be on a strict diabetic diet to limit carbohydrate intake, to limit bad carb intake. You know, you've heard of the glycemic index, so eating processed sugars is really bad for diabetics. We want people to exercise or to be physically fit. It's very effective to control blood sugar levels by burning calories. So the more active people are, the more physically fit you are, the more you're burning those calories and the more your body as a machine can process that glucose and burn it off so you don't store it as fat. And finally, weight loss, plays a key in that. As a matter of fact, the more body fat that a human being carries, the more insulin resistant you are. So that's one of the reasons why type 2 diabetes is intimately related to obesity and body fat content. Obviously, for type 1 diabetics, they need to be on insulin. You have to replace the insulin because your body isn't making it. So mealtime insulin, when you're eating glucose loads, people have to take short-acting insulin. You can use long-acting insulin for a base as well. For type 2 diabetics, we can use oral medications to treat. Usually that's, initially when we diagnose with type 2 diabetes, we can use oral medications. There's now injectables that are non-insulin injectables, which I'll talk about here. And then it's not uncommon for type 2 diabetics, unfortunately, to come to the need for having insulin treatment. Usually it's long-acting insulin as a base, but we do frequently treat type 2 diabetics with insulin eventually. So a lot of drug classes for treatment of diabetes, mainly type 2. So these are oral medications. First and foremost, the biguanides, metformin would be the main one in there. Glucophage, trade name. This is a mainstay of treatment for all diabetics. The way it works in the body is we call it a sensitizer. So it causes the body to use what insulin you have better. So it kind of fights that insulin resistant problem. So if there's no contraindication, I think all diabetics should be on at least metformin to start for that very reason, because it can lower your insulin needs. So that's a big goal in treatment of diabetes. There's two classes. The first two really that came out, oral medications for diabetes, sulfonylureas and thiazolidinediones. I practice that word a lot. I'm not going to say it again. So you've heard of glipizide, glimepiride, glucotrol, Actos, Avandia. These were the first oral agents that have come out. Very good in their time. They worked great. They do have significant side effects. Like I said, they're the initial ones that came out, they're older. I don't really prescribe these anymore because the newer agents are much better, in my opinion. Usually I'll keep people on these meds because of cost. They're very cheap. The newer agents are very expensive, so sometimes we have to keep people on these agents, but they are very good still. DPP-4 inhibitors, Januvia, Onglyza are examples of that one. They're pretty good. Usually we use those maybe a third line add-on drug for people. A newer class that has come out, SGLT2 inhibitor, sodium glucose transport protein 2 inhibitors. Invokana, Farxiga, Jardiance, those are the big three in that drug class. This is a very unique drug class, very good class of medications. They work uniquely in the body. They block resorption of glucose in the kidneys. So I like to tell patients, think of it as you're urinating out excess sugar. So that's a unique way to help control blood sugar. The unique mechanism of action of these medications also give a very good renal protective benefit. So we can actually use these medications for chronic kidney disease, even in non-diabetic people. So these meds have a lot of extra benefits other than lowering blood sugar. There is some cardiovascular risk reduction as well if we use these. So these are very good class of medication. Talked about insulin. There's rapid acting, short acting, intermediate, long acting. You might have heard of, Lantus and Levemir, those types of meds. Toujeo. There's a lot of long acting types, a lot of formulations of insulin. And then finally, what I want to talk about today, GLP-1 receptor agonists. Glucagon-like peptide-1 receptor agonists. So the biggies in this drug class are Trulicity, Byetta, Victoza, Saxenda, Mounjaro, Ozempic, Wegovy, and Rybelsus. So all of these medications are injectables. They're weekly injections, except Rybelsus. Rybelsus, while it is semaglutide, which is the same molecule for both Ozempic and Wegovy, those are injectables. Rybelsus is an oral daily pill. So these are all in the GLP-1 receptor agonist class. The more popular ones shown there. So how do these work in the body? How do they, what's so great about them? First thing it does, they stimulate glucose-dependent insulin release in the pancreas. So again, for type 2 diabetics, those who still are making insulin, when you take on a glucose load and use these medications, it enhances your insulin release to process that glucose load. Because again, type 2 diabetics have a problem with when they take on a glucose load, that insulin release might be variable. You might get a lot one day, you might not get a lot the next meal, so your blood sugar levels can be erratic. And again, glucose-dependent insulin release. So these medications are known, I've been told by drug reps, they're smart medications, whatever that means, but they truly are, because they only work when the glucose levels are high. That's why we can use these medications for non-diabetic people for weight loss. So if your glucose levels are normal, it won't make them go lower, so to speak. So they're smart medications. One of the big mechanisms, and we'll talk about this in a little bit, is they slow gastric emptying. So normal food goes into stomach empties out. Takes about an hour and a half to 2 hours. So these medications slow that process. When we eat a glucose meal, a carbohydrate meal, which is carbs are in everything, after that meal, you can have a hormone called glucagon released. Glucagon tells your liver, hey, put out a little more glucose just to be safe. Think about when you sleep at night, you don't eat food for 8, 10, 12 hours. And if you don't have glucose, how's your brain going to get energy in your body? So there's a protective mechanism in the body where we release glucagon, and that tells your liver, put out a little glucose to cover that fact that you're not eating. So diabetics, this process is abnormal. So usually people who are diabetic release too much glucagon after a meal, so your sugar goes up even higher. So that process is abnormal. So these medications kind of inhibit that from happening. And another big way that these medications work, and in particular Mounjaro, is they decrease satiety. And I'll talk about that in a second here, but satiety means you feel full. So you feel full faster. You don't eat as much. So I'd like to focus in on two of these mechanisms, the slowing of gastric emptying and the decrease in satiety. So I tell patients this all the time. Think about you eat lunch at noon, like we're going to do here shortly. That food stays in your stomach again, hour and a half, 2 hours, it slowly empties out. By dinner time, 5, 6 o'clock, your stomach empties, you feel hungry. So these medications slow that process down. Might take 4, 5, 6 hours for that food to leave your stomach, depending on how big of a meal you ate. So by eat lunch, by dinner time, your lunch is still in there. You're not hungry. And so you're not as hungry, you won't eat as much, you feel full for a lot longer, you're not thinking about food all afternoon, decreases your appetite. And then when people do try to eat with a full stomach, you get sick. You feel nauseated, some people vomit. It's a main side effect of these medications. One of the biggest, in my opinion, discoveries in the brain that we have discovered is a satiety center. So we know that there's an area in the brain that controls how full people feel. So heavier people tend to have a higher satiety, meaning they have to eat more food to feel full. And that's can be a brain function, not just a full stomach function. There's a big feedback mechanism there, but we've discovered that if this satiety center can be lowered, you won't eat as much because you feel full faster. So we've discovered that these medications work on that center in the brain, so that's why they can be very effective at weight loss. Again, people feel full faster and with less food. So why is this beneficial? Obviously, we eat less and we lose weight, or you can now get closer to your ideal body weight. Not everybody needs to lose weight. We want to be healthy, so we want to be at our ideal body weight. Because of that, we take in less glucose or less carbohydrates, and that controls our blood sugar, makes our diabetes much better, thereby reducing the risk of heart disease and stroke. So these are the studies that were done, the clinical trials were able to show that these medications reduce the risk of heart disease and stroke. Because of that satiety thing that I talked about, people, some observational things that we've seen with these medications is people tend to report, oh, I'm not drinking as much alcohol as I used to. I just don't have a craving. I just don't want to drink as much. Or cravings for opioids or nicotine even. People are stopping smoking because they're just not feeling the craving for these substances. So these medications are being looked at very closely to treat certain addictions as well because of that satiety issue. Currently, the FDA has only approved 2 of these medications in this class for weight loss. Wegovy and Saxenda. Wegovy is semaglutide, that's the same molecule as Ozempic. And Saxenda, liraglutide, is the same molecule as Victoza. So my first question is, okay, Ozempic, Wegovy, what's the magic? They're the same molecule, come on. But what the drug companies do is they will market a molecule under a different name for a different FDA class. So they named the same molecule Wegovy, that's for weight loss. Ozempic is for diabetes. And I mean, there's some subtle differences. Wegovy formulations, the dosages are a little bit different, so that's why they can get away with that. Same with Victoza and Saxenda. Word has it, or rumor was, that Mounjaro or tirzepatide would be approved for weight loss at the end of October. I don't think that's happened yet, but by the end of the year, Mounjaro should be coming out with the FDA approval for weight loss. There are reports that these classes of medications, you can lose up to 12 to 15% of your body weight. That puts this class of medications at the top of any weight loss drug we've ever had to date. I mean, 15% of your body weight is an amazing result of a weight loss drug. Usually 5 to 10 with what we currently have would be a great outcome, but these are even better. So a little bit about off-label prescribing. That basically means when a medication is prescribed for a condition other than what it's FDA approved for. So some common examples: aspirin, FDA approved for fever, pain. We use it commonly for cardiovascular disease prevention. Take your 81 milligram aspirin a day for that. Gabapentin is probably the most common one we use off-label. There's a million off-label uses for gabapentin: restless leg, anxiety, neuropathy, hot flashes, headaches, back pain, chronic pain. Gabapentin is a seizure medication, so I know it's kind of gone off the deep end, in my opinion, for all these other indications. Selective serotonin reuptake inhibitors, you might have heard it: Prozac, Zoloft, Lexapro, Celexa, Paxil. These are great medications for depression, anxiety. However, off-label, we use them for migraine headaches, chronic pain, hot flashes, to name a few. So I'm talking about that because we are now using Ozempic and Mounjaro off-label for weight loss because they have such great results. Well, we might be using it off-label for addiction medicine as well. So why is that? Well, Wegovy, as you can imagine, there's a hugely high worldwide demand for Wegovy for weight loss. Obviously, obesity is a huge problem worldwide, so this medication is very highly sought after. Novo Nordisk is the drug company that makes it. They have actually proactively limited availability of Wegovy because they can't keep up with demand. So when that happened, we prescribers say, well, Wegovy is the same as Ozempic, should have the same results for weight loss, so I'll use Ozempic or Mounjaro for weight loss. They work really well. However, in doing so, we've now created shortages for diabetic patients who need these medications. So talk a little bit about compounding pharmacies. Does anyone work in a compounding pharmacy? I don't know. So if a drug falls on the FDA drug shortage list, that happened during COVID, then a compounding pharmacy can compound that drug. Semaglutide, Ozempic, Wegovy, is on that shortage list. And so compounding pharmacies can compound this to get it out to people. However, to get the actual molecule, semaglutide, they have to go through Novo Nordisk to get it. As you can imagine, Novo Nordisk isn't all too willing to give up their molecule to just anybody because they want to, control the supply themselves. So it's hard for compounding pharmacies to get the actual correct molecule. So what some compounding pharmacies have been doing is using the salt form. They're inventing it themselves. The salt form of semaglutide sodium or acetate. That's not a good idea at all. The FDA has labeled these molecules as for research only or not intended for use in humans. And the FDA has made a statement, the salt forms of semaglutide have not been shown to be safe and effective. So we have to be very careful with what exact formulation is out there. I know there's scores of internet companies that are sending these meds out, which not a good idea. So now my anecdotal data. I've been using these meds for about the last year or so. I've started to get on board with the program. One of the measurements we use to manage diabetes is something called a hemoglobin A1C. That's a measurement, a blood test, and it kind of measures how much glucose is stuck to your red blood cells. Red blood cells float around your body for about 120 days and then get replaced. So that can give us an idea of what your blood sugar average has been for the prior 2 to 3 months, 120 days. So it's a very good measurement we use to manage diabetes. I have seen drops in A1C from 1.5 to 3%. These are enormous drops because any one oral agent will drop your A1C about 0.8 to 1.2% max. So if we need to drop somebody's A1C from 10 to 7, then we need at least 2 oral agents, if not 3, to get you down to goal. So these meds are pretty effective at doing that. I've seen great weight loss as well in periods of time as short as 3 months, which is not a long time. 10 to 15 pounds is what I'm seeing. I'll put a patient on these meds, I'll see them back in 3 months, and They're down 10, 15 pounds very routinely. I've had some patients up to 30 pounds in just 3 months, which is pretty darn good. I have been seeing issues with toleration. So just like I said, these medications can cause people to have nausea, vomiting. And I tell my patients, the medication is not making you sick. It's your eating habits that are making you sick. In my opinion, that's a very potent feedback mechanism to eat less. If you're eating the way you normally eat, I have people tell me all the time, "Oh, Dr. Sullivan, I eat great. Why can't I lose weight? I only eat once a day." When they start on these medications, they realize that they're not eating great, that they're eating too much because they get sick when they eat too much. So this toleration, in my opinion, is directly related to people overeating. Just a shout out to you guys out there in the pharmacist world. I think it's critical to counsel people on these new meds. I try to do it in my office when I give it to them, but we don't have a lot of time to do that. So it'd be great if you guys in the pharmacy could help patients understand how these medications work. That would preclude a lot of worry and people stopping these because, "Oh, this drug's making me sick." Well, maybe it's because we need to change our eating habits so you can tolerate it a little better. That is a big counseling item that I tell patients. If we're having such great weight loss, maybe people won't need as many blood pressure meds or as much insulin. That's a big one. If we're dropping their A1Cs 3 percentage points, that's bringing their blood sugar down over 3 months. If a person's already on insulin, we really got to knock back the insulin. And that's a goal for treatment in treating diabetes is, we want to use the least amount of insulin we can to control the blood sugar. So that's something that patients need to know. They need to closely monitor their other conditions. Nutrition's always a great thing to counsel people on. We can't hear enough about nutrition. But think about it, if someone's not hungry anymore and they're not eating, then they're not going to eat. And when they do eat, if it's not the right stuff, nutrition goes out the window. You still got to have nutrition. I tell people every day, you got to eat to lose weight. You have to eat to lose weight. You can't just not eat for 3 days and expect to lose weight. Your body goes into starvation mode. So if you're eating proper nutrition, you will lose weight. It's just the amount you're eating and what you're eating. So that's a big counseling point I'd like to make. And like I said, if we're dropping blood sugar like that, now it's not like insulin. It's not like taking short-acting insulin and you get all of a sudden hypoglycemic. Blood sugar levels drop over a period of time. So it's slow. So it's not like you're going to pass out because you don't have any sugar. But over time, if you're losing weight, not eating as like you were before, sugars are coming down. And if you're on other treatments for diabetes, we really need to look at that and throttle back on those. As far as safety, obviously any new medication, you're not going to have a lot of data for long-term safety. There is limited data because they're new. Biatic came out in 2005, Ozempic 2017, Mounjaro 2022. We do know there is low risk for hypoglycemia as far as what I described. These are non-insulin medications. So you don't inject them and then your sugar drops to 50 and you pass out. That, again, they act in a glucose-dependent manner. So if the glucose is already high, they're going to work. If your glucose is normal, They won't drop you more. That's why we can use them for weight loss in non-diabetic people. You can't use insulin in non-diabetic people. That's a very bad idea. The hypoglycemia comes over time when the weight's coming off and we're eating better. That's what I'm talking about there. There is a black box warning. Medullary thyroid cancer, if you have a personal or family history of that, is an exceedingly rare type of cancer. I've only seen a couple cases in 20 years, but that's something that we need to be aware of. So that's a hard and fast safety issue with this class. There have been some reports that these medications might cause pancreatitis or add to it, or pancreatic cancer. A lot of the new diabetic medications that have come out have the same issue. You know, we think, well, if it's messing with glucose-dependent insulin release from the pancreas, then maybe it irritates the pancreas. So almost all of the new medications that we have for diabetes will have this warning about pancreatitis. But for this class in particular, no evidence has been shown to date to link it. It's just something we got to keep an eye on. Maybe someday they will link it together, but as of right now, there's no evidence to link pancreatitis or pancreatic cancer with use of these medicines. There's a condition we call gastroparesis. So that's stomach paralysis, or that condition happens in people with long-term diabetes, especially if their control has not been great. So the stomach, the function of the stomach could be blunted, or so their gastric emptying is already slow. So these people have what's known as gastroparesis. So if someone has that already, these are the worst medications you can give them because it'll compound that. Do these medications cause it? No, they do not. But if you already have underlying gastroparesis, you should not use these medications. Theoretical risk of small bowel obstruction, again, no evidence to date showing these meds cause small bowel obstructions. However, there's you can theorize, well, if I'm eating, slowing down the gastric emptying, that slows down my digestion, so then I might get a small bowel obstruction if I'm not moving stuff southward very quickly and I keep eating up top. And so, again, there have been some small bowel obstructions in people who happen to be on these medications, but there's no direct link. Real patient. This is one of my patients. Success story. So 63-year-old white female. This is a pretty darn common patient that I see in my clinic. Type 2 diabetes, hypertension, obesity, cholesterol issues. So she comes in for a routine follow-up. This is her medication list. So Lantus, long-term, or a long-acting insulin. We don't usually, I'm sure you see it a lot when you're filling scripts of these long-acting insulins, broken up BID. I don't know why we do that. It makes us feel better, I guess. But they're 24-hour acting. You're not supposed to do that, but sometimes we do. But anyway, so you can consider her being on 80 units of Lantus, metformin. I put her on Jardiance about 2 years ago for the kidney benefit and to bring her A1C down a little bit. Again, I'm using that class of medication usually second line now after metformin. Blood pressure, she's technically on 3 different blood pressure medicines: irbesartan, hydrochlorothiazide, it's a combo med, and amlodipine, so 3 blood pressure meds, and her cholesterol med, atorvastatin. So there's her vitals, just like the first lecture we had. Weight was 226. That put her BMI about like 34, 35, body mass index, given her height. Blood pressure, 138/88, just like that. The vital sign lecture said that's not where we want it. And then our hemoglobin A1C was 8.9%. All diabetics, we want to be below 7. So that's where she was when she came in, and she's feeling fine. No, no worries. She's just like, I'm here. You made me come in. So I'm like, all righty. You just want to pay off your boat. No, I don't have a boat. So what are our treatment goals for this patient? So yeah, I want her weight down. If we can get her below 180, that would be wonderful. That's about almost 50 pounds for her. That'd get her BMI more under the 30-ish, 29, 30 range. Like I said, our A1C goals for all diabetics are under 7. Lower is better, but I want to keep her under 7%. Again, that equates to an average glucose of 154. And then, ideally, human beings' blood pressure should average always 120s and 70s. That's just pressure on the pipes. We want to keep it 120s and 70s all the time. 130s and 80s, not great long term. So here's a conundrum. What can we do for this patient? Well, obviously, eat a better diet, exercise, lose weight. That's the first thing out of my mouth. And everybody's like, right, okay. Easier said than done. I know that, I get it. But I gotta say it. It's like, quit smoking and eat a better diet. So what else can we do medication-wise? Well, I can increase her Lantus. 80 units, fairly moderate to high dose. You hate to increase insulin if you don't have to, because the more insulin's a fat-promoting hormone, by the way. So the more insulin you have, kind of the more body fat you'll tend to carry. So it's like a two-edged sword. Yes, you need it to control your blood sugars, but high levels of it, it's not a great idea. I can add short-acting insulin to cover her meals. Sometimes that's an effective way. Sometimes I'll just cover the largest meal of the day, all right? You're on long-acting. If you have one meal that is larger during the day, why don't we give you a little Humalog to cover that meal, and maybe that'll help overall control your blood sugar. But again, that's another injection or another 3 injections, more insulin. We don't like to do that. We can add, the older diabetic meds, sulfonylureas, TZDs. Those are cheap and very readily available. A lot of side effects, especially meds like glipizide, glucotrol. It's almost like giving insulin. It'll make you hypoglycemic whether your sugar's high or low. So I don't love those. The DPP-4 like Januvia, we could add that. Expensive, but again, her A1C was 8.9, and we want to drop her at least 2 points. Any one oral med will get you down maybe 0.8 to a point. So would adding Januvia get you anywhere, or glipizide? I don't think so. Or we could add a GLP-1, which I did. Why I chose Mounjaro over Ozempic, I don't know. Maybe I didn't see the Ozempic commercial soon enough in the most recent past, so it wasn't on my mind. All of these Ozempic, Mounjaro, we usually start at the low starting dose. This is 2.5. I think Ozempic's is 0.5. That's not even the efficacious dose, but you want to do it for a month to make sure they tolerate it. Because if you started on the normal dose, everyone would be getting sick. So I put her on 2.5 a week for 4 weeks. left everything else as is. At the end of 4 weeks, she came back in. Hey, I'm tolerating it great. She felt good, so I put her up to the 5 milligram dose. And then I'll usually, once I bring them back in a month, make my boat payment, I'll wait 3 months to bring them back after that. So 3 months of treatment on 5. Here's how she came back. I couldn't have asked for anything better. She was 198 pounds, which was 28 pounds of weight loss in 3 months. Dropped her A1C 3 points. Now think about that, because this is an average over 3 to 4 month average. So you have to be under the average to drop it. You know what I mean? So she went from an average sugar in the upper 200s to now 120s in a pretty short amount of time. Blood pressure dropped, because she dropped, almost 30 pounds. Her blood pressure is going to come down. And she was feeling that. So she's like, oh, I have no energy. I feel dizzy when I stand up. I'm tired all the time. I just feel terrible. What have you done to me? And I'm like, I fixed you. And I'm going to fix you more, because I decreased her insulin from 80 total to 20. So I dropped her insulin 60 units. And I got her off one of her blood pressure meds, amlodipine. I dropped that. And I've since seen her in follow-up. All of those symptoms went away. She's feeling great. 6-month follow-up, her A1C was about 6.1%, still great, still on the 5 milligrams of Mounjaro. So, and the weight she's actually down, I think she's like in the mid 180s now, and she's very happy person. So one of many success stories I've had in the recent past. Ozempic, miracle drug? Well, certain Beverly Hills housewives seem to think so, even though they deny taking it. Very promising class of medication, in my opinion. They're extremely effective at controlling blood sugar and for weight loss. And whenever I prescribe a medication, I always look at the mechanism of action of that medication and see how it's beneficial for the patient. So some medications I won't prescribe just because I'm like, that is a dumb way to work in the body. It's not going to help in the long run. These help immensely because they slow gastric emptying. You're full all the time. You're not going to eat as much. Because of that, you lose weight, and your blood sugar gets under better control. Lowers that satiety center. Every human being, by the way, we all eat till we are full. There's no human out there, I don't care who you think you are, you will eat till you feel full, and then you will stop eating. People who diet, try that, lasts about a week, but you can't not eat till you're full. It's just a human evolutionary reaction. So if you can lower that satiety center in the brain, because that's what controls it, and you feel full faster, you won't eat as much. Yay. Now, who doesn't eat more? One more bite, gotta do it. I do that all the time, but that's just how it is. So these meds are very effective at doing that for weight loss. As you well can imagine, and I'm sure across your desk, you're seeing tons of these prescriptions being written, Ozempic, Wegovy, Mounjaro. What are you seeing most of, by the way? Ozempic?
Wegovy and Mounjaro.
Yeah.
Mounjaro you can get a hold of now.
Yeah. I've had the most success with Mounjaro to get for people. Now, insurance, I'll usually prescribe something and let them tell me what they cover. I'm not going to do research. I'll usually, and it's about 50-50, you know. Some companies are like, we like Ozempic, we like Mounjaro, we like Trulicity, you know. So whatever the insurance likes, you know.
See, Mounjaro used that coupon,
Oh, okay,
and
yeah.
then they pulled the coupon.
Oh, okay.
Initially, it was like $25.
Yeah,
50,
Yeah.
500, and
Yeah.
now the coupon's no longer.
no
valid.
longer available. Because huge demand has caused shortages. Please beware of the compounding pharmacy formulations. I read a market estimate, $100 billion drug class by 2035. I believe it because the first billion-dollar drug was Viagra. It's just the condition it treats is out there, and obesity is a big problem worldwide. So if we have an effective treatment for a condition that's very common, it's going to be a $100 billion drug. I don't disagree with that. Yes.
So with this and with these, you have to keep using them to keep the weight off? So it's gonna be, unless you're gonna, do you hit a plateau? Because in our clinic, it's for diabetic only, it's
Yep.
not approved for weight loss.
Right.
So, but when they hit that plateau, they have to wait until they can move up to the next level.
So that's the $100 billion question. So her question was, do you have to keep using these medications to continue the weight loss benefits? Is there a plateau? And I'll add to that, do you just jump back to where you were before?
Yeah.
Yes, if you go back to the way you were before. My contention as a medical physician is use these medications to train the brain and figure out how to eat better. And once you start losing weight, you'll start exercising and feel better. And it's a whole cyclical pattern of behavior to change. There's no magic pill for weight loss. These are close to magic, miracles, but yes, if you stop taking it, your stomach will then empty in an hour and a half. And if you, and you'll not feel, you'll be hungry all the time again. My contention is the feedback mechanism of I eat, I get sick, Pavlovian, oh my God, 3 months, 6 months, I think at least 6 months, people should be on these meds to and then be cognizant that I got to change my eating habits. It's not an automatic. You can keep it off by coming off these meds. I've had a couple patients like that. They just changed their whole life. And it really helped them do that. It's a very difficult thing to do on your own, as we well know. But if you can have a feedback mechanism of feeling nauseated when you overeat, I think that's very effective. So yes, people say, well, when I stop taking these meds, I'll gain it all back. That's true with any diet. That's true with anything you try to lose weight, unless you change your life. Yes.
Wait, I have a lot of questions, so sorry. Do you find yourself, because of the availability, writing the dosage that's available, or do you stick to?
Nope. Her question is, do I find myself writing prescriptions based on what's available out there? I don't know what's available, so I just write for whatever.
Okay, 'cause we're finding constantly, hey, we don't have this, but
Yeah.
we have the next dose, contact your doctor.
Yeah, and that's why I rely on you guys to tell me that. I don't know, so Walgreens might have it and Baker's won't. I don't ever prescribe based on cost or availability, just because I don't usually know that information. I don't know what insurance people have, and this is going to be covered and this isn't. I just write for what I think is appropriate and then work with them when the pharmacy says, well, that'll be $968 a month versus something else. So, yeah.
Knowing that people would rather take a magic pill than a magic injection, why isn't Rybelsus?
So, very good question, one that I have. So why isn't Rybelsus taken off? It's a pill every day. and versus an injection every week, I don't have a good answer, other than it's $8,000 a day to take, or whatever.
A box,
Yeah.
I just did a price check on it yesterday, even with the coupon. So we got it down from $8,000 to $6,000 per box.
But again, I don't know why. To me, pill form would be better than, nobody likes an injection. I agree with you 1,000,000%. I haven't had great success getting it covered versus the injection. Maybe that's why. But you're right. I mean, I'd rather do a pill. Yes.
So you said insulin is kind of like the last step, or you want like the lowest dose you can start with?
Yes.
How do you know when to like bump up metformin base or like to move to that next tier? Is it we start with metformin, if that doesn't work, we move to the next, then maybe a Jardiance, then an insulin?
Yep.
Or do you skip from like metformin to Jardiance to insulin?
Very good question. Yeah, so this is with all disease states and with all medications. So her question is, how do you know when to go to insulin? How do you know what to prescribe first, the next, the next? So with a lot of disease states, there are recommendations based on experts, so the American Academy of Diabetes puts out expert opinions on what you should do. Metformin first, second line should be SGLT2s. Reserve insulin for later. So yes, we kind of go off guidelines from expert opinion. They come out with new guidance on every disease state. Hypertension, cholesterol, diabetes is a big one. So they're always coming out with new guidelines on, COPD. What, do you go to a triple therapy first, Trelegy, or do you stay with dual? So we kind of follow those, hopefully you do, and keep up with the times, but usually the base is metformin. I try to hold off insulin as long as you can, and when you're not getting good control on 2, I'll usually pull the trigger on insulin if I'm on 3 oral meds and not getting that goal, that A1C goal. Hey, it's time to go on insulin. My goal is always to get people off insulin too. So if we can get them to goal, and then they can do some weight loss and exercise and change their diet, I'll take you off insulin in a heartbeat. Good question.